In patient with a drowsiness, he needs verbal stimuli to respond for a while. Stupor, it needs more vigorous stimuli, which is painful stimuli, and the response will be shorter than that in drowsiness. In coma, coma is the extreme of disturbance of level of consciousness. We called it eye closed coma. What do you mean by eye closed coma? This is a coma, but we label it as eye closed coma to differentiate it from something else, which is vegetative state. Patient with eye closed coma is not persistent state, and most of the patient stay no more than 3 weeks. After that, within that period, up to 3 weeks. Sorry. So before that, the patient have one of the three pathway: either death, or improvement, or they have improved partially, to some extent, that he developed something called awake coma. This is to differentiate from eye closed coma. Awake coma is what we call it persistent vegetative state or minimally conscious state. There is no big difference between persistent vegetative state and minimally conscious state. There is only one difference, that in minimally conscious state, there is some sort of responsiveness, but it's very few. What do you mean by vegetative state? Vegetative state is coma with eye opening. They're just like sleep. He have unresponsiveness. He's definitely comatose, but the sleep-wake cycle, in a way or another, is preserved partially. So the patient have opened his eye, and when the time of sleep come, he closed his eye. This is what we call it vegetative state. This is just like extra time. Coma is not a persistent state and end in 3 weeks, no more than 3 weeks, plus minus. But in vegetative state, the patient make time to recover. So this is it followed the comatose state. If he develop a kind of response called minimally conscious state, and the same for vegetative state. Usually, if the vegetative state persists for more than 1 month, called persistent vegetative state. There is apparently three primary type of lesion depress the state of arousal. Arousal, a sense of stimuli, it means the level of consciousness. Either direct insult in reticular formation of the upper part of the brainstem, or bilateral diffuse huge cerebral dysfunction, or unilateral cerebral, like in this figure, but associated with herniation. And herniation, it means part of the cerebrum compress the brainstem. So in a way or another, it is a brainstem insult, pressure on the reticular formation of the ascending reticular system. Reticular formation from the mid, if we have a imaginary line in the mid of the pons, the reticular formation in the upper part of the pons and midbrain, if a lesion or insult to this reticular formation cause disturbance of level of consciousness. This is the only three situation that the patient develop disturbance of the level of consciousness. Disturbance of content of consciousness is something different. It is inability to maintain a coherent stream of thought with usual coherence, clarity, and speed. Disturbance of content of consciousness divided into confusional state and delirium. So what is confusional state? This widely used term, maybe in inappropriate way most of the time, but it's have a specific, precise meaning. Confusional state defined as inability to maintain coherent stream of the thought. Maybe the patient have full responsiveness. The level of consciousness is full, but, and the Glasgow Coma scale is complete, but inability to maintain coherent stream of thought or action. لا جملة مفيدة ولا عمل مفيد. Distractibility, in other words, it's inattention, one of the hallmark of the condition. It's often evident in the conversation. It is lapse in the ability of concentrate on a stimulus. The condition typically develop over a short period of time. يعني in general, we call the confusional state acute confusional state and tend to fluctuate during the course of the day. This is characteristic. يجي المريض، يجون أهل المريض، يقول دكتور الأمور زينة قعد وكذا. No, it is fluctuated. Any episode of regaining of the comprehension, awareness, it doesn't mean everything is good. No, but continuous regaining of the awareness, it means the patient improve. It is fluctuated even in the the cause is ongoing. He may be patient, for example, سنرجع بعدين على causes. The cause is hyponatremia. Without improvement in hyponatremia, the patient may have some kind of improvement, fluctuation. This is characteristic for confusional state. To fulfill the requirement of the definition of the confusional state, the patient should have full array of manifestation. It means that all the cognitive function is impaired. We use the 5 in examination of confusional state, a patient with confusional state, to detect the confusional state, 5 cognitive domain. This cognitive domain called domain of communication, attention and concentration, memory, orientation ما ادري ليش ما كاتب sorry orientation مكتوبه, orientation, reasoning and judgment, and speech. These 5 should be impaired totally, not only one. If you remember, in cerebellar ataxia, we need only one function, one test to impair to designate the patient as cerebellar ataxia. Here, you cannot say the patient is confused, but orientation is preserved. Cannot be. It should be all these cognitive function is impaired. In a way or another, apparently, attention and concentration should be examined preliminary. The first one, because if the attention and concentration is impaired, there cannot be any kind of cognitive function is preserved. So inattention is a hallmark of the confusional state. Delirium. What is delirium? It is confusional state. All the characteristic feature of the confusional state is compatible for delirium with agitation, and agitation is dominates. This is what we call the delirium. We have two terms widely used: dementia and encephalopathy. Dementia is defined as a syndrome consisting of chronic, acquired, generalized, progressive impairment of cognition. But here in dementia, existence of two impairment of two domain is fair to fulfill the requirement of the definition, in contrary to the confusional state, which need full array of manifestation. So dementia and encephalopathy, later on I will mention it, is related to cognition rather than the consciousness. I know quantitative consciousness defined as impairment of cognition, but here only two domains of cognition, not all cognitive domains. Encephalopathy is a wide term, disturbance of cognition, acute or chronic, with or without disturbance of consciousness. Maybe a patient with encephalopathy, especially acute, develop disturbance of consciousness, but it's not necessarily. So encephalopathy related to the cognitive function rather than the consciousness. There is some condition that mistaken for coma: locked-in syndrome, akinetic mutism, psychogenic unresponsiveness, and brain death. Brain death is beyond coma. Psychogenic unresponsiveness, I think Dr. Adey mentioned in details. Catatonia may be the distinctive feature differentiate comatose patient from psychogenic unresponsiveness. Locked-in syndrome, it means a lesion in the base of the bones, that the patient have tetraplegia, inability to speak, and horizontal movement of the eye is impaired. He only move the eye vertically. Those patients, most of those patients diagnosed by the family rather than the doctor, they are conscious in a way or another, but mistaken as coma. The only way that you realize the patient is conscious by asking the patient to look upward or downward. He will obey this command because this is the only movement he can control. Akinetic mutism, something different. This is related to the extrapyramidal system. Difficult in initiation of movement. He looked quiet, looking forward, but he did not move anything unless you motivate them strongly to do it. يعني تخلي اللقمه بحلقه، يمكن يبقى نص ساعه يلوش شويه ما يبلعها. ابلع 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 يلا يبلع اللقمه. زين. Need a motivation. Maybe the distinction between comatose and akinetic mutism is he's can concentrate in moving object. يعني اذا تحركت قباله ممكن يظل يباوع عليك وين ما تروح. This is the only way. There's another condition that is mistaken for confusional state or delirium. Aphasia. Aphasia is circumscribed cognitive function. Here there is a defect in comprehension, especially طبعا, if we said the aphasia and how differentiate aphasia from confusional state, this is sensory aphasia, disturbance in comprehension. So how we can differentiate this patient and differentiate patient with aphasia disturb the comprehension, but patient with confusional state disturb of all cognitive function, comprehension and another. How to differentiate? Differentiate by the patient with aphasia have normal daily habits, يعني thinking normal عنده بس he cannot communicate with other. Agnosia هي neglection, but if he ask him anything he can communicate but he neglects. Psychosis, transient global amnesia is a condition that for episode maybe minutes, hours, days, that the patient have loss of memory and then regain everything, forgetting what happened in this episode. Depression, as you know, should be differentiated. I mean, you know what is depression. Should be differentiated from confusional state. What is the causes of disturbance of consciousness? In Arabic language, we call what I will do muqaraba. List is very, very long. But to narrow this list, we have first to differentiate between level and content, and then we need another factors to make the list short. First of all, in fact, that both activating ascending reticular activating system and the cortex is important for the level and content, but the level mainly activating reticular activating system disturbance and content mainly cortical disturbance. Okay. The cause is divided into structural and non-structural. Structural, in general, it means neurological cause. Non-structural is systemic disease that disturbance of consciousness is a reflection, neurological reflection of the systemic disease. Structural, non-structural. Okay. Causes either diffuse or focal. Okay. Diffuse lesion mainly non-structural. Mainly. The English have a proverb. The exceptions make the rules. So we describe the rules, but it doesn't mean there is no exceptions. And maybe if you know, we memorized the exceptions, make the rule applicable. Diffuse disorder affected the content of consciousness, at least initially, albeit initially. What is the itemized differential diagnosis for disturbance of content of consciousness, which is diffuse disorder? Metabolic disturbance, hypoxic ischemic encephalopathy, hypertensive encephalopathy, septic encephalopathy. اتذكر دول الأربعة. Any patient with if we label this patient, the first step in management of disturbance of consciousness is categorization the patient. What kind of disturbance of consciousness? If we said this patient is confused, it means disturbance of content of consciousness. There is one of four: metabolic disturbance, hypoxic ischemic encephalopathy, hypertensive ischemic encephalopathy, septic encephalopathy. But you should remember that any patient with confusional state, if you found a focal lesion, and again a diffuse, there is an exception that 3 types of diffuse lesion give focal: hypoglycemia, non-ketotic hyperosmolar diabetic coma, hepatic encephalopathy. This kind of metabolic disturbance, which is diffuse disturbance, which give disturbance of content of consciousness, may give focal lesion. It doesn't change anything. This is metabolic disturbance, which is caused disturbance of content of consciousness. Focal lesion, in turn, focal lesion mainly structural. Focal lesion affected the level of consciousness. What is the focal lesion? Any insult of the central nervous system: traumatic, vascular, infectious, autoimmune, neoplastic, and degenerative. Is there any exceptions in that? Yes, with a few exceptions of structural lesion. Intracranial hemorrhage, any kind of hemorrhage, definitely any kind of hemorrhage is focal, but give disturbance of content of consciousness. Intracerebral, subdural, subarachnoid, it can give focal. Non-dominant parietal lobe lesion. البارحة طلعت مريضة من الطابق. Non-dominant parietal lobe lesion, focal, but the patient have confusion state. CNS vasculitis and epilepsy. The last picture. Post-ictal state. Here focal secondary generalized, but the patient have post-ictal state disturbance of content of consciousness rather than the level of consciousness. During the attack, he level, but followed by disturbance of content of consciousness. And maybe you not maybe for most instance that you see the patient in this state rather than in the ictal state. ما يلحق بما يجيبوا لك اياه للمستشفى هي دقيقتين السيجر. So you encounter a patient with disturbance of content of consciousness and proved later on that the cause was seizure. All of the metabolic encephalopathy, the degree of neurological change depend on large extent or rapidity in which the serum change occur. Sometimes the patient يجيك 125 serum sodium and he's in a way or another consciousness preserved, and other patient in the same completely confused, definitely confused, because rapidity, this is the make the difference. Brain can adapt, and especially brainstem have capability for adaptation, but rapid change difficult to be adapted. Clinical approach. بس الامور واضحه لحد الان؟ واضحه الامور؟ نمشي؟
نعم تمام.
ماشي، ماكو سؤال يعني. خوش. All these background knowledge we should know to help us in clinical approach. We need an applicable approach. The usual approach to any patient with any kind of disease for us now is with any patient with disturbance of consciousness is obsolete, and all the traditional concept no longer concern us. The issue need a new roadmap. Okay, يعني القانون لا ينفى إلا لا يلغى إلا بقانون. It doesn't mean I cannot have that step-by-step approach which is suitable to most of the patient in disturbance of consciousness because of rapidity of brain damage, I should use another approach, but it should be plausible. The main goal for management of patients with disturbance of consciousness is characterizing the nature of the disorder. Is it content and the level? And if it is level, what level? If it's content, what kind? Is it confused or delirium? To identify the cause and where it's possible, correct it. Provide appropriate protection for the brain to reduce further damage. Okay. Often, the cause of impairment of consciousness is not immediately evident, and diagnosis require orderly approach. Rapid impairment of consciousness is a medical emergency and require urgent assessment and treatment. The patient needs treatment even as the etiology being investigated to uncovering the underlying medical illness that has caused. The assessment and the treatment are performed jointly in a practice. This is the difference in approaching the patient with disturbance of consciousness, that the assessment, clinical examination, maybe investigation, and the treatment is intermingled to each other, but intermingled in orderly pattern. So we need a special philosophy. Still, history have fundamental position in management of disturbance of consciousness, but don't waste time in vain. It doesn't mean I don't say don't waste time in taking history, but those time in vain. And you should have a concise history, a focus history, but focus on what? First of all, what is the source of information? The patient now have disturbance of consciousness. So he's not a resource of information. So we need to have another resource for the information. Either the witness, the family, the emergency medical technician, he might provide information. يعني زين sometime يعني هذول يعني وين السبعينات برا اللي يخلوا لهم يا مقلاده او معبد يكتبون عليه هو دايابيتك وكذا يعني. or if you have previous admission ندز على تشارت اذا الاهل قالوا ترى داخل عندكم كل فتره نجيبه يصير هيجي زين all chart زين. اوكي. Devote the rapid history obtaining by emphasis on two things: the temporal profile, the most crucial aspect of the history, mode of onset, time course, and the chronological evolution. The second is the prodromal feature, and put the disturbance of consciousness in timeline with herald events, what happened before he lost his consciousness. You should ask about injury, infection, convulsion, previous illnesses. Is he diabetic? Is he have renal failure? Is he have heart disease, hypertensive? Review of medication, ingestion of drug, alcohol, other toxic substance. With that, there is an emergency management. Acute respiratory and cardiovascular problems should be attended to before the neurological assessment. ABC, airway, breathing, circulation. ABC is for detection and the treatment of life-threatening condition. This is have the priority. The cardiovascular and respiratory have the priority to the before neurological assessment. Okay. Any immediately reversible cause identified should be treated. يجوا الاهل دكتور هو عنده صرع وعارف الدواء وهسه صار به. That's it. The cause of disturbance of consciousness is seizure or status epilepticus. دكتور هو هذا المريض مريضنا عنده سكر اخذ الجرعه مع الانسان بس هو ما اكل. This is hypoglycemia. برا يعني طبعا عندهم الهايبوثيرميا والهايبرثيرميا بالضروره الثلج وكذا هايبوثيرميا. Okay. There is what we called it phase 1. For me, I called it baseline investigation. Phase 1, what do you mean by phase 1 investigation? These investigation should be requested for any patient with disturbance of consciousness. Unrelated whether the cause is clearly evident or not. And this is your job. Don't wait for more authorized healthcare يعني السينيور البيرمننت. لا انت روتيتر بالطوارئ you should do this زين as rapid as possible to all patients with disturbance of consciousness. This is phase 1. Then with that, after that, whatever, assessment of grading of disturbance of consciousness. For the level, we have Glasgow Coma scale. For the content, we are evaluated by conversation and differentiate from the mimic condition for each, for the level and for the content. Examination. In examination, we don't go to the examination thoroughly. يعني medical and general physical and neurological examination. The policy is to go over a new solid data for the disturbance of consciousness and pass over the irrelevant data. So we start with temperature, which is very important, vital sign. ABC, we cover other vital sign. Here we start with temperature, evidence of a trauma, and don't forget, a trauma, it doesn't mean head injury. Any patient with head injury, try to find if there is neck injury, because neck injury highly associated with a head injury. Meningeal irritation sign, which can point to meningitis and subarachnoid hemorrhage. Fundus examination of papilla edema denote increase in the cranial pressure. Examination of the skin, nail, mucous membrane may give us hint for many problems. Eye movement and eye position should be noted. Brain stem reflexes. We have reflex for the related to the midbrain, pupil size and reaction to light. For the pons, corneal reflex. For the medulla oblongata, gag reflex. In comatose patient, eye movement should be tested by stimulating the vestibular system. This is all the investigation in a step. I put it in one slide because I want you to know that this is the same slide, but I added for that, I put a neuroophthalmic examination in red to make you recognize that the crucial aspect of neuroophthalmic examination and examination of patient with disturbance of consciousness. It's very important. Next lecture بعد ما يخلص دكتور عبد الكريم ان شاء الله الاسبوع الاخر الاستاذ عبد الكريم عنده انطيكم النيورو ophthalmology in general and neuroophthalmic examination have this crucial aspect in examination of neuroophthalmic examination of unconscious patient encompasses of spontaneous eye movement, vestibular and oculocephalic reflex, fundus examination, pupillary examination. I will start from pupillary examination. Size, symmetry, and reaction to light. Pupillary light reflex is very resistant to metabolic dysfunction. Usually, the patient with disturbance of consciousness, the reflexes is disturbed in what we called it caudal rostrocaudal pattern. يعني the midbrain, pons, medulla oblongata. If the cause is metabolic, there is exceptions. The patient may have pontine reflex impairment with a preserved pupillary light reflex. يعني اتذكر مريض كان intracerebral hemorrhage جايب disturbance of consciousness فكان يعني الاكسبلانيشن very clear that intracerebral hemorrhage cause hernia and cerebral herniation cause disturbance of consciousness. This is clear, so clear. But one of the residents mentioned that the pupillary reflex is preserved. So it's definitely not the explanation. It is not the explanation of the disturbance of consciousness. Yes, the patient have and found to be with phase 1 investigation that the patient have renal failure. And the intracerebral hemorrhage was a complication of renal failure. This and the plan of treatment changed completely from pupillary light reflex as a hint. Okay, the oculocephalic reflex by means of passive head movement and vestibular ocular reflex by stimulus of ice water irrigation against tympanic membrane. I will have any. I will not give you any detail about vestibular ocular reflex because it's no more used. يعني mentioned in the books بس كافي بس اذكرها. Oculocephalic reflex is something different. With the brain stem lesion, both reflexes are absent or abnormal. Oculocephalic reflex is of the head is abruptly rotated from one side to other in horizontal or vertical. The reflex usually suppressed in conscious patient. هسه اي واحد من عندنا يعني ياخذ يحرك راسه راسا العين ترجع بالنص اللي هي يعني اليوجوال بوزيشن مالته. احرك يمنه very short latency تبقى لا من العين بالنص. If the patient have disturbance of consciousness due to cerebral lesion, the eye طبعا they mentioned that the eye go to the opposite side, does not go to opposite side, but it's still in the same side. وانت حركت يعني move the turn the head to the right, هي بالحقيقه تبقى بمكانها تبقى بمكانها ما تروح للرايت وياك. يقولون the turn to the opposite side. هي يعني actually she still in the same position. And the brain stem lesion لا تصير paralyzed, تصير لايك دول اللعابه اللي عينها ثابته وين ما توديها عينها بالنص. يعني just like the normal بس هنا الفرق هو unconscious البيشنت. هو هنا أنا ما ادري ليش من شيرت ما يشتغل سوري ما يشتغل When the oculocephalic reflex is present, the eye do not turn with the head, but in the opposite side direction, as if the patient is maintaining visual fixation on a single point in space. كانوا ده يبقى بقى على مكان واحد. Actually لأنه الcerebrum control the movement, like upper limb movement, lower limb movement, ocular movement. فif it is impaired يعني loss of control للcerebrum on the movement تبقى واقفة. Respiration, either the smell of ketone with alcohol can give a hint for the cause. And respiratory pattern in hemispheric coma, kinestok respiration. In midbrain coma, central neurogenic hyperventilation. Central neurogenic hyperventilation is highly deadly regular. Pontine coma, apnostic breathing, prolonged inspiratory cramp. Medullary coma, ataxic breathing. يصير irregular, completely irregular. Motor system examination, we have three kinds of posturing: decorticate, decerebrate, and flaccid. Decorticate, it means the lesion above the red nucleus in the midbrain. Decerebrate, it means the lesion either it is below the radionucleus either in the midbrain or the pons. Flaccid paralysis, I have no photo for figure for flaccid paralysis. Flaccid paralysis, it means the lesion below the pontomedullary junction in the medulla oblongata. At this time, if there is no obvious cause, we should use what we call it coma cocktail, providing that no focal lesion, no meningeal irritation signs. Coma cocktail consisting of glucose, thiamine, naloxone should be used. هسه راح تقولوا لي زين هو يعني الفيتامين بي 1 very rare to cause. Okay, fine. الهايبوغلايسيميا common. Why we use vitamin B1? Vitamin B1, although it is rare, nevertheless, if you give glucose in a patient with vitamin B1, it means you will aggravate the condition. So you should give vitamin B1 initially, then glucose, then naloxone. Naloxone, the antidote of opiate, but practically diazepam more common as a cause of suicidal attempt, of overdose than opiate. Opiate مو كلش متوفر يعني. زين why do we give naloxone as a case of as a in coma cocktail rather than flumazenil, zenenil? Because naloxone not harmful if the cause is not opiate induced coma. Opiate as a offending agent for coma, for disturbance of consciousness. But flumazenil, if it is given in a patient with antidepressant overdose, which is common cause in suicidal attempt, it will precipitate a status epilepticus. So we cannot give something يعني الانتيدوت for diazepam cannot be given on suspicion. We should be sure that the cause is diazepam overdose to give its antidote. Then, for this level, we have general physical and neurological examination. And going in this way is not a thoroughly examination. Start by detect hydration, tympanic membrane, chest, heart, and abdomen. If the patient, we didn't reach the diagnosis for this stage, we start with phase 2 investigation, EEG, brain MRI, lumbar puncture. It is recommended in a specific clinical scenario, including those cause remain obscure after phase 1. This is need يعني more authorized people to give the order for performing this kind of investigation. Phase 3 investigation, this is a specific laboratory studies. يعني مرة دي يسألني دكتور خالد انه ليش الchest x-ray this cheap available, why do you put it in, why يعني مو I put it يعني as a in general put in phase 3 rather than phase 1. It's not يعني the issue is not the cost. We put phase 3 as investigation of phase 3 in a specific condition related. If the chest is clear, there is no rule to do chest x-ray. We put it in a specific situation to confirm or exclude some possibilities. In selected patients, when a specific condition are suspected, phase 3 investigation are required instead of phase 2. يعني احنا okay, we called it phase 1, phase 2, phase 3, but it's not mandatory to do it in sequence. phase 1 ما بيها مجال، شفتها بالطوارئ you should send for phase 1. You should prepare it for the more authorized to present with the presentation of the case. But phase 2 and phase 3, if there is no hint for anything, we should send for phase 2. But in a specific situation, we send of phase 3 instead of phase 2. Now we reach the principle of treatment. Treatment related to the to the cause. But as a principle, neurological recovery is often depend on early treatment. Specific treatment of the underlying causes must be commenced as quickly as possible. Good nursing is needed to preserve orientation, prevent pressure source and falls, and maintain hydration, nutrition, and continence. The use of sedative should be kept to minimal. I think in management of disturbance of consciousness, two crucial aspects. طبعا التريتمنت shifted toward the cause. هذا المريض is it intracranial hemorrhage, is it hypoglycemia, but nursing is very important, at least to prevent complications. Using of sedative and طبعا argued against using of sedatives. Remember, disturbance of consciousness doesn't mean coma, and something else. Usually we ask about sedative in patients with delirium. So sometimes we need to use delirium in patient with coma, with the sedative in patient with delirium. But you should remember that to use it in at least as possible dose and for shorter time, just to overcome the mixing between, is it deterioration due to its initial disease, or this is due to sedation. and thank you very much for your kind attention. إذا